I'll just start off by some introductions. So I'm Jyoti Sood. I'm a GP in Redbridge. I'm also the Redbridge Diabetes lead. I also am the clinical lead for social prescriber workforce, hence my interest in the two areas. I'm joined today by two of my excellent colleagues in Redbridge, without whom I don't think I'd be able to do any work in Redbridge. So I'm going to ask Imran if you could just introduce himself, please.
Yeah, sure. My name's Imran Khan. I'm a clinical pharmacist with a specialist interest in diabetes. I work part-time for the medicines management team in the CCG, and I also work part-time in GP primary care in South Ilford.
Hi,
Thanks,
I'm
Imran. Amita, go on.
Hi, I'm Amita George. I'm the diabetes specialist nurse. I'm the diabetes team lead at Redbridge Diabetes Centre at Northeast London Foundation Trust. Thank you.
Thank you. We've got a lot of interference. If people will just mute themselves, please, that would be really helpful. Thank you. Can people please mute themselves? It's really loud. Now it's better. Okay, lovely. So as I mentioned, that I've got an interest in diabetes and also in the personalized care practitioner's role. And I was just thinking about how best we bring the health and the social care model together. I've been struggling. I think I've been doing diabetes, what, 14, 15 years in Redbridge. And as much as I wanted to try and bring and look at the wider determinants, there was always a gap in terms of the time pressures or lack of services around managing some of these patients. And you then had to then adopt just a medical model, keep increasing the medication without really looking at those wider aspects of things. So when the PCP roles came through, I thought it was an ideal opportunity to try and amalgamate the two models, and hence my interest, and this is why I'm here. I've labeled this as part 1 because I really thought of starting the sessions with giving a basic information about diabetes, having a discussion around some of the gaps and how people are getting on and what they're doing locally, with the view of getting some information to influence and inform our second or part 2 of this program, which I hope will be a rolling program as we go along. So today will be really basic things, but by all means, put as many questions as you want to in the chat function. This is the opportunity to ask, and if you want to just not come on the view and just put it on your chat function, please do. I'm going to move on to the next slide, please, Erin. So the learning outcomes today, I'm really hoping we would have a good idea or understand what pre-diabetes and diabetes is and the types, understand the care processes and the annual health checks or annual checks for diabetes, some of the targets we'll mention, understand what complications the patients can have, and some of the challenges in diabetes care, but also importantly discuss what local services are there and actually start maybe reflecting on some of the gaps. I've got some case studies which we can then try and see what the personalized care practitioners, the role in pre-diabetes and diabetes is. But also, more importantly, I'd like you all that are joining here today to let us know what those other learning needs are to then, as I said, and come back with the part 2. Next slide, please. Thank you. So these are some facts and figures. So again, I remember looking at them every year and being absolutely shocked. So we've got 4.9 million people in the UK having diabetes. Erin, before you move on to the next one, can I ask people how many, and just put some figure in the chat function, how many do they think are undiagnosed, or how many do they think have pre-diabetes, not have diabetes yet, but high risk? Just put some figures. So how many people are undiagnosed? If you want to speak up, otherwise put in the chat function. Anyone? What's the numbers? 8 million? Okay, Jackie, 1 million? Yeah. Okay. So this is undiagnosed, 10 million. Okay, all right. Should we reveal the answers, Erin? Okay. So actually, there's 850,000 people, as we know now, that are undiagnosed. So, that's what we say, the tip of the iceberg. We've got lots of people out there, that don't know they've got diabetes. Next fact, please. And 13.6 million are pre-diabetic. That means all these people are going to join the blue line soon, and that will have the impact on the next bit, which is, Erin, next line, please, which is the cost. So at the moment, it's 10% of the NHS budget. Moving on, we're looking at 17%. So actually huge. And diabetes is, I think, one of the chronic diseases that cuts across. It's the only condition I know that affects literally every organ, every organ. So, and hence the cost. And these are just direct costs. We haven't even considered the indirect costs of people that have had strokes and, you know, that have had amputations, etc. So next slide, please, Erin. And I have missed an important statement here, sorry. It's just to say that actually most of the patients when we talk about will have type 2, that's 90%. A small percentage will have type 1. There are other forms of diabetes. So just to let you know, when people talk about diabetes, majority will have type 2. There will be type 1, but other form of type, you know, there's type 3C and, you know, other pancreatic diabetes, etc. But for really this purpose, it's type 1 and 2 that we'll focus on. Next slide, please. Now, this is an important aspect for you guys to consider with the people and the clients that you're working with. Who do we screen? It's an important question because I think the goalpost keeps changing, and but there are guidelines. So at the moment, as it stands, all patients over the age of 40 get an NHS health check every 5 years. So that's the group that everybody would screen anyway. However, if you're on certain ethnic groups, and this is all picked up from NICE, you start getting screening from the age of 25. Furthermore, there are other conditions that will put you at higher risk of type 2 diabetes, and that would be, I've listed them, and again, not surprising to most of you, if you've got a heart problem, if you've got blood pressure, if you're overweight, you've had a stroke, you've got some, you know, hormonal problem like the polycystic ovarian syndrome, if you've had diabetes in pregnancy, mental health disorder and learning disability, and also if you've got fat around the liver, so it's fatty liver disease, as we call it. We also know steroid also increases your risk. Now, just to let you know, according to NICE guidelines, and this is what you might find some of your clients and patients mentioning, some patients get an annual check for diabetes. Some will get 3 yearly, some 5 yearly. That's what NICE is saying, low risk, medium risk, and high risk. All high risk annual, the medium risk 3 yearly, everybody else 5 yearly. However, in practice, I think most of our patients, certainly Imran, I don't know what you feel, most of our patients probably get them annually. Is that your experience as well, Imran?
Yeah, I think unfortunately most of our patients are in the high risk area. In South Ilford, we've got a very big South Asian population anyway. And unfortunately, you know, obesity is also quite a big problem. So if you're South Asian or Afro-Caribbean or, you know, Far East Chinese, and you're obese as well, you know, you carry a really high risk. And also, I think, you know, with deprivation, you know, you get your mental health issues, you get, you know, a poorer diet, you know, they're more likely to be doing, you know, the chicken and chips because it's cheap, it's convenient. So, you know, when you factor in all of these things, we do have probably the majority of patients fall into high risk. So we would be looking to check annually.
Yep, I absolutely agree. So it's just for people that are here on the call today, and I see there's a wide range of roles here today. It's just make sure that you're able to signpost people to having these checks done, particularly based on the age, the ethnic background, but also the risk factors here. But I completely agree with you, Imran. I think it depends on area to area. Certainly in our patch in Redbridge, we've just appear to have all people at high risk. Okay, any questions, comments so far? I can't see any in the chat function, but any hands? And Erin, I'm having trouble seeing hands, so I'm going to rely on your eyes to do so. Anything so far before we move on? Okay, no, great. So next slide, and I'm going to hand over to Imran.
Okay, thank you very much, Dr. Sood. So pre-diabetes, what is pre-diabetes? So this is a stage before we can, you can say is an intermediary stage between not having diabetes and actually having diabetes. And the way we work out if a patient is pre-diabetic, we can do through blood tests. So you will possibly be familiar with HbA1c. This is a 3-month average of what a person's sugar is. So often you will get somebody to say, oh, no, you know what, that blood test was wrong, because it just happens that morning I had chocolate cake. I never have chocolate cake for the rest of the year, but on the morning of the blood test I did. And you can explain to them, well, that chocolate cake didn't make any difference because this is an average over 3 months. And in terms of HbA1c, and this is something I always explain to patients, okay, is a normal is up to 41, 42 to 47 is a pre-diabetic stage. And if you have a HbA1c of more than 48, that then becomes a diagnosis of diabetes. You can also do this through fasting sugar. So in this country, we do 5.1 to 6.9. If your fasting sugar is in these levels, you're pre-diabetic. Interestingly, I think you will bear with me that I think it's a good idea. In the States, they've lowered it. They've lowered it to 5.1. The idea being that you pick up these pre-diabetics earlier, and that hopefully we can make the intervention at this stage. I think it's about 50%, correct me if I'm wrong, of pre-diabetics will go on to develop full-blown diabetes within the next sort of year, 2 years.
In 2 years.
So this is 2 years, isn't it? So actually, this is very crucial, especially for you guys, to make the interventions at this stage when they're at the pre-diabetic stage. Because we know that if you tackle pre-diabetes and very early diagnosis of diabetes, the long-term benefits for the patient are huge. They're massive. So in other words, tighten the belt early is what I say, because as they've become diabetic and they're diabetic for many, many, many years, decades, then unfortunately you're not able to control the diabetes so well. And in fact, it may even be detrimental to them. So at this stage, these things are crucial. You know, the lifestyle, the way you look at food, your understanding of food, you know, your attitude towards physical activity. And I think that's a good way of saying to somebody, do more exercise. So any way you can increase your physical activity, you know, maybe walk a little bit more. Walk up and down stairs instead of taking the lift. Because remember, if you say to somebody, oh, you need to go and do 30 minutes of exercise, you know, 3 times a week, what do people think? They think, oh God, here we go. I'm not going to join a gym for a start. You know, I don't want to be amongst those people. I can't afford to do that. I haven't got 30 minutes every week. I got 3 kids, you know, young kids. I'm going to work. So how you sell it to the patient, client, is very crucial. It's got to be done in a way that makes it feasible for them. So, you know, even for sometimes in South Ilford, I have women who don't want to go out. They may be covering or whatever. I said, that's fine. Walk from the front door to the back door 20 times and then go up and down your stairs 5 times. And do that 3 times a day. It's doable, isn't it? You're in your own home and every little bit helps. So this is a crucial stage. If you find patients in your practice, in your areas who are pre-diabetic, honestly, this is the most crucial stage in their diabetes because we want to reverse them. And all the studies now show if you can lose a bit of weight, you increase your activity, you modify your diet, you can reverse your diabetes 100%. What's your opinion on that, Dr. Sood?
So I think, Imran, there's there's increasing evidence now that, you know, previously we thought you can control it, you can actually reverse it now. There's enough evidence through trials
Exactly.
that at this stage you can definitely delay. And I don't know of any condition that's got such a high conversion rate. 50% is massive.
Yes, exactly.
Pre-diabetes to diabetes.
Yes, exactly. Exactly. Right. Next slide, Aaron. Next slide, please. Thank you. So what is diabetes? So I touched on that in the previous slide, which is in terms of diagnosis, we have a HbA1c of more than 48. That's the standard that we use now nationally. If it's a low 48 and the patient doesn't see, 48, 49, 50, that kind of reading, patient's not got any symptoms, then we normally do a second HbA1c just to confirm before we give a diagnosis. Now, I'd like to ask our wonderful audience here, in terms of symptoms of diabetes, what kind of things do you think you might expect patients to tell you? What kind of things in a diabetic may come to you and say, I've got this going on? And anybody?
Like, is it thirstiness and also needing to go to the bathroom a lot?
Yes, absolutely. Yes. So these are things that we call osmotic symptoms, but honestly, don't worry about these words. The main thing is exactly what you said: increasing need to pass water and also thirst. Anything else? Any other sort of symptoms, signs that you might see?
Imran, somebody's entered a tiredness, dry mouth.
Yes, absolutely. Exactly. Dry mouth. I think I might be. I'm very dry at the moment. So yes, dry mouth and tired. Yes, somebody's put weight loss. So if you have very high blood sugar, probably you've been diabetic for some time, which has not been diagnosed, you can actually get weight loss. Anybody want to guess why you're getting weight loss? Throw a guess. It doesn't matter if what it is. We're all here. Why do you think you would get weight loss with with diabetes, very poorly controlled diabetes, very high diabetes? Anybody?
I think Sophie's got a hand.
Well,
Imran, Sophie's got a hand.
Yeah.
Hi.
Go on,
Hi, I think
Sophie,
it's,
tell us.
hello. I think it's the inability of the body to break down the sugars to convert it into energy.
Yes, you are quite right in a respect. The body obviously is not utilizing that sugar, and because the sugar is in the blood goes to the kidneys, and actually what is happening is you pee out sugar, right? And what do you think the consequences are of peeing out a lot of sugar? Anybody?
Well, you're not using the sugar.
Have a guess. What's happening if you're passing a lot of sugar in your urine?
Imran, I think Ninian, do you want to come in?
Well, because
Yeah.
you're not consuming the sugar, so then wouldn't that cause the weight loss?
Yeah, exactly. So that's the reason. But because you're not consuming the sugar and it's coming in your urine, what do you think you might be more susceptible to?
Urine infections?
Have a little think. Pardon?
Urine infections?
Absolutely. Urine infections and also potentially thrush. So a lot of people who've got poorly controlled diabetes and nobody knows they've got diabetes, they may be prone to urinary tract infections, or they may be constantly coming and saying, you know what, I get thrush all the time. So when you hear somebody, oh, I've had 4 urinary infections in the last 2 months, you should ask yourself, oh, I wonder if this patient is a diabetic. So these are some of the telltale signs. Another one is slow wound healing. So normally you cut yourself, you get a little scar, it starts to heal, a few days it's gone. But when you're a diabetic, it takes longer to heal, even small little scars and stuff. So diabetes then, HbA1c of more than 48, which means you have more sugar in the blood, because the sugar has not gone into the body, as you quite rightly all have pointed out very nicely. So it's not being used for energy. So you're feeling tired. You may start to lose weight because all of that excess sugar, especially there's a lot of it, is being, the kidneys can't filter it back in again. So it's all going in your urine and you get all of these signs and symptoms. So very important, if people are having urinary tract infections, thrush, when you speak to them, you know, have they got wound healing? Do you feel thirsty? Are you passing more water? All of these kind of things, very important. Next slide, please. Okay, so this is very important. What happens at diagnosis? So a patient, normally in a surgery, doctor will see them because they've come in and the doctor says they are TATT, tired all the time, right? So they say, I'll tell you what I'll do you a blood test, because let's face it, a patient would like something done. So you do a blood test and you say, I'll check your iron levels, I'll check your hemoglobin, I'll check your sugars as well at the same time. And what happens? Their sugars come back and unfortunately they're in a diabetic range. So we repeat it normally, especially if they're asymptomatic. If they have symptoms, lots of symptoms of diabetes, then really you might not need to repeat it. You repeat the blood test and then you have to call the patient. And this is where, you know, patients are already apprehensive. Why did they ask me to repeat my blood sugar? Something must be up. Oh, I hope I'm not diabetic. That means insulin straight away. All of these kind of thoughts go in their head. Now, what I'm going to tell you next is very, very important. No matter what the level of their HbA1c is, give them hope. All right? Diabetes can be reversed. I have had patients who have had a HbA1c of 136. Dr. Sood, we worked on it. Within a year, that patient was at HbA1c 42. So never, ever let that patient not have hope. Because if you tell somebody, oh, you're stuffed, you're diabetic, there's no way out of this, you know, it is going to get worse. What do you think their attitude is going to be? They're going to think, oh, well, if it's already done and dusted, I'm just, you know, might as well phone the funeral people, you know, start paying monthly, because there's no hope for me. So for me, the biggest thing is I always say to them, yes, your HbA1c is in the diabetic range. And then the next thing I do is I explain the numbers. Please don't just say to a patient, oh, your HbA1c is 65. And the patient nods his head, says, yes, okay, nice. What does that mean? Is that good? Is that bad? So I give them the full scale, up to 41 normal, 42 to 47 pre, 48 or more diabetic. And then I tell them what number we want to try and aim for, whether it's 53 or 58 or less than 48. But I always say to them, look, let's reverse this. The good news, so the bad news, okay, so you've got a HbA1c of 65. Okay, no problem. This is where you are with your HbA1c. But here's the good news. You and me, we can work with this. Yeah, I'll help you. I'll give you all the support that you need and all the wonderful people like social prescribers, dietitians, the whole team. We will work with you. We can reverse this. You don't have to be on this medicine forever. We can make you non-diabetic. And that is the hope that they want. Once we've done that, we will explain about complications as well, because I think that's important to know at the beginning. And Amita is going to talk to you about the complications. So I explained the complications. And the reason I explain the complications early is this. If I say to a patient, you need to go for an annual eye screen, but I haven't told them why, what do you think is going to happen? What am I going for? They DNA. If I tell a patient, I need to check your urine at least once a year, but I don't explain to them I'm checking their kidney and that diabetes can affect the kidney, they don't go. If I don't explain to them why am I checking their cholesterol, why am I, checking all of these things, why should a patient go and get it done then? Honestly, I swear to God, Dr. Sood, this is absolutely true. Every patient that I've ever dealt with at diagnosis now comes to the surgery and demands every year their annual health checks, the 8 health checks. They actually say, you haven't done it.
And Imran, that's the stage I would love for every practice to be at, because this is self-empowerment. So this is how giving figures, explaining, these are the wider things. As you rightly said, if I say to somebody, all right, I'm sorry to say that you've got diabetes now, here's metformin, here's what you need to do, off you go. 10 minutes, next patient. It just doesn't do the job. It just doesn't. And which is where I am so pleased we've got the PCP workforce around to help support that patient. So really well said, Imran.
Yes, absolutely, which is really nice that we've got all this wonderful team that are here today to help us support that. So what I will do is I'll explain all of this to the patient, and then at the same time, I book the foot check. I book the dietitian. I give them a form to get their urine ACR done, which is a check for the kidney. And I give them a blood test form and say, let's get all of this done now. These are the things that we're going to aim for. And I always check again in 3 months and give a follow-up. Because if you don't do that, the patient thinks you're not serious with them. Whereas if they have that follow-up of the HbA1c in 3 months because you said you were going to follow up, they think, oh, that Imran, he is not going to be off my case unless things change. So we do all of these things right at the beginning. The other thing we do is we refer for structured education, which is with the wonderful Amita. They provide a fantastic, incredible service, and Dr. Sood. Because we don't have enough time in the surgery to give a proper, full in-depth feedback on their condition and what they can do. And these lovely people can. So we explain the benefits of it because we want them to turn up. And if you just say, oh, by the way, I'm going to refer you for structured education, and they get their appointment, half of them don't turn up. But if you explain the benefits of it, explain why it's important and how much they will gain from it, there's a good chance they'll turn up. Dr. Sood, I talk too much. And once again, I'm talking too much.
Not at all, Imran. I think
So,
really relevant
is there
points.
anything else you would like to come in?
No,
is there anything else you would like to come in with this?
No, I just wanted to say, I think your approach is absolutely fantastic, and that's the ideal approach we want people to get to. But unfortunately, not everybody in the same place. So it's just for people to be here aware of what happens at diagnosis and the care process. We'll go into slightly more details a bit later. But I just wanted Imran to talk through what happens at diagnoses. And this is where I think the structured education bit is where we've got poor attendance, where I think perhaps some of the PCP workforce can, or anybody who's actually on the call, if you're aware, people haven't attended, maybe discuss the benefits of attendance. But the problem with this, the approach, it's looking at that doctor-centeredness. I want to now try and see where we can amalgamate the doctor-centeredness with some of the social aspects of the wider. So, just referring a patient who works 9 to 9 to structured education, which is available 9 to 5, is probably not a good idea. So it's now looking to see if you haven't attended, why? What's the problem? Because I probably haven't thought of that. Do you see what I mean? Or in which case that there might be other aspects like, the online bits that might benefit some patients rather than attending a structured education course. So it's just, I just wanted us to start thinking slightly wider. But Imran, really well said about the key aspect about motivation and self-empowerment of the patient, really. So well done, Imran. I think I don't speak too much, but you speak, really well. So well done there. I'm going to, next slide, please, Erin. So Amita, would you just take us through complications?
Okay, hi everyone. Thank you, Dr. Sud. Yeah, complications. Have you remember the slide in the beginning? We said around 16.6 billion pounds NHS spending for diabetes. Do you have any guess how much we are spending for the complications from that? Any idea?
Again,
you can type.
say or type, yeah.
So we are about to spend around 16.6 billion by 2035 for the whole diabetes management. So can you guess how much they will be spending for just complications alone? 9 billion. Yeah. Okay. Same again. Yes, around 80% of that money we will be spending for complications alone. So that's around 13.5 billion just for the complications. So that's why I would like you all to understand what's the complications, how we could prevent, because most of these complications we could prevent. That's and we could save that money and we could use that for another good purpose. So most of them preventable. Yeah. So any idea about what's the diabetes related complications? Hopefully you might seen some people with the diabetes complications. Do you know the diabetes complications? Please type if you know. There are many.
Heart diseases.
Parkinson's, you say?
Heart.
Loss of limbs, eyesight, yes. Yeah. Ulcers, yeah. Multi-organs failure, yes. Well done, well done. Yeah. Kidney failure, neuropathy, glaucoma, you all know the complications, yeah?
And
Yeah,
Sophia,
well done. Thank you.
Sophia's brilliant.
So,
Sophia, you can come really good.
yeah. Yeah. So there are, we could just divide the complications into two groups. Yeah, thank you. So we could divide the complications to two groups. That means macrovascular and microvascular. You know, macrovascular, you know, the term macro, what that means, macro. You can say that. It's big, yeah, it's a big blood vessels, yeah. And micro means it's small blood vessels. So I'm just going to divide the complications which related to big blood vessels and the small blood vessels. Okay, so you all know, but I'm just repeating the same. So big blood vessels, say which organs in our body have the big blood vessels? You can say or type, no problem.
What was the question? Sorry.
Which organs have the big blood vessels? Say if it's the heart, brain. Yeah. So they have the big blood vessels. So the diabetes complications we say which will affect the big blood vessels and the small blood vessels. Okay. So heart, that mainly heart attack. There is a high risk of heart attack on type 2 diabetes patients, and stroke, that's affecting the brain. Yeah. And peripheral vascular disease, that means the lower limbs. You know why? When the blood sugars are very high, it's not talking about those who are diabetes is well controlled. So if their diabetes is well controlled, they'll be free from all these complications. Yeah. When the diabetes is very high, obviously the blood pressure also come and join. And then the fat levels in the blood also goes high. So these three became very high and they are risk developing the stroke and heart problem. That's what happened in diabetes mainly. Yeah. And this, as I said earlier, we could prevent. The main thing is, Imran mentioned earlier about the annual screening, isn't it? So if they go for a regular, at least once a year, their blood pressure check, their weight check, their cholesterol check, is all we identify in early and we treat them early so we could prevent it. Problem is, as most of the time, the patient may not attend or they don't really know why they has to attend that appointment. So then they miss it, and probably once they're diagnosed after 3-4 years later, they will be checking all these. By the time they develop, already they got the one of the conditions. Yeah, that's one barrier at the moment. Another thing is the diabetes. You mentioned. You remember in the first slide we said most of them, they don't know they have diabetes. So they're living with the diabetes. So once the time they diagnose, probably they may get all these most of the complications. That's another thing. So that's the importance of identifying the diabetes earlier, also a very key thing. So when we talk about the small blood vessels, which organs have the small blood vessels? Just type or you say. Nobody. Which organs have the small blood vessels? Legs. Yeah. Any other organs? Which organs is going to affect the diabetes? Is affecting the kidneys? Yeah. Yeah. Okay, good. Well done. So mainly our eyes, our kidneys, and peripheral nerve systems. Yeah. So they are having very tiny blood vessels. So mainly, if we talk about eyes, behind our eyes, that's called retina, and they have very tiny blood vessels. So what happened when the blood sugars are high, when the sugar levels in your blood is very high, the blood became so thick. So the blood vessel starts to dilate. When it's dilates, so imagine if you blow a balloon, if it's too much, if you blow, what happened? The balloon will burst, isn't it? Same way, the blood vessels behind their eyes can burst, and that can result in losing their vision. They may lose their eyesight. Yeah, so that's why we're sending them for. If the patients comes to you and talk to you, you won't be able to identify whether they have any diabetes-related eye problem. Yeah, so we need to send them for a diabetes eye screening every year. So if you explain to them the reason why we're sending for diabetes eye screen, they will go. Yeah. So that will help us to identify any problems with their eyes in early stage. And just for your information, the diabetes eye problem is the first complications which the diabetes patients developed during their diabetes period, because first starts with the eyes. So that's another one important thing. We send them for a diabetes eye screening. The next one is the kidney. Kidney also same, the very tiny blood vessels. So they starts breaking it, and then they leak protein in the urine. So that's also, we also identify through the annual check. So Imran mentioned albumin, creatinine, urine test in the urine. So that's through that we will identify the any issues related to kidney in early stage. So again, it's important we reinforce them to go for the annual urine test. So the problem is they don't know why they need to give the urine. So they just ask for, oh, just giving the urine out. Most of the time they miss it out. So if when they comes to us, to you, but you guys can ask, have you been for an annual check? Sometimes the term they don't really familiarize. So just ask them, have you gone for a diabetes eye screening? Have you given your urine out for the urine check every year? So just will check your kidneys. So if you ask them those questions, they will tell you, yes, I did, or oh, no, I don't. So if they don't, just ask them to go to the GP, or you could ask the GP to request those tests for them. Another thing is, most important is the neuropathy. Most of the time, the time of diagnosis, some patients may tell us they have neuropathy, because the main reason is they diagnosed very late. When they diagnose very lately, that means they have diabetes. They are living with the diabetes for like 10 years, and that's the time probably they diagnose through a random blood test. They may develop neuropathy already. So we can't reverse that neuropathy back to normal, but we could prevent the further damage. Okay. So the main thing is like ask them or send them for an annual food check. So when they do the food check, we're able to know whether they have any damage to their nerve system or nerve damage. So mainly they will check in whether they whether they have the sensation on their feet. Yeah. So if the patients tell you that, say, I find it's very difficult, I feel all the time tingling sensation on my feet, I cannot sleep, or I have a numbness, you could ask them, have you done your diabetes food check? If they say no, please send them for it. Yeah. And another thing, if they say to you that they have those symptoms, what you will advise? Do you give any advice to the patients? If they say that, oh, I have no sensation on my feet, I feel very numbness most of the time, any advice do you give, or is it something new to you? Looks like, yeah, get a blood test, raise legs. Yeah. In diabetes, when we come to diabetes, it's very important to tell them about their food care. Yeah, refer to GP. Yeah. So foot care means, their nails that needs to be trimmed. There is a risk of, if they need to check their feet every week, I just tell my patients to check your feet daily, because if they don't have much sensation, if they don't get a numbness on their feet, if they are injured, they don't know if there is any ulcer in there. So especially if you imagine if it's an old lady and if she can't see on her feet, and if she injured her feet, she don't feel the pain. So she will stay like that with that for probably a couple of weeks. And probably when she get the bad odor, she realizes that something not right with her feet. By the time the wound might be infected. Yeah. So it's the foot care is very important. And when the wound is infected, that's the time we say it's the poor wound healing in diabetes. Yeah. So wound is not, yes, patient can lose their toes. Yes, obviously. Yes, the wound is not infected. If infected, they need it treated. And if it's not, if the blood sugar is very high, there is a high chance of amputation. Yeah. So that's we could prevent if we just advise them about the foot care. So just most of the time they will tell us, they have, some people say mainly the first time they will experience the numbness on their feet, and then it's on their hands. They say they could not put the buttons on, they could not feel the sandwich bag. These all are symptoms of the neuropathy. But it's difficult to get an appointment now. Myself has been referred over 6 months. Oh, that's, is it with the GP, you mean?
Okay,
Yeah.
Natasha will answer that question in a minute. I think it's in the next bit. So hold on to that.
Yeah. Okay. So the another thing is the sexual problem. So both men and females, they may report to you that they have recently noticed, since they're having diabetes or lately they are not interested on sex, or they have any sexual issues. If they mention to you, don't ignore it, or don't think that it's related to something else. It can be related to diabetes because of the neuropathy and lack of poor blood circulation. Yeah. So always refer that to GP. Sometimes that can be linked to any cardiac problems as well. So don't ignore any of the symptoms if they mention to you, because sometimes people don't open to everybody. So if they are very close to you, they will tell you everything. So just refer that to the GP about that. Yeah. So and moreover, even though if all these common complications, but remember, when the sugar is high, that is in the blood, it's all over our body, isn't it? The blood passes everywhere. So the diabetes can affect all systems. All systems, not just not only one particular area, it's everywhere. So most of the time, because of the long-term illness, say diabetes or asthma or any other long-term condition, hypertension, they may then go to a depression stage. So that's also we need to be looked at. So if anybody says they are in a low mood, you could direct the GP for them to have a further review. Okay. Anything else, Dr. Sood?
No, just thank you, Meeta. Just to say that I've actually seen an elderly lady who came in with exactly that her feet smell. When I've looked at her feet, there was a gaping, maggot-filled wound under her on her heel, which she had no idea about. Poorly controlled diabetic. So it's seen a lot there. Yeah, seen patients just collapse, heart attacks. It's really devastating to see some of these young people being affected by complication. So I'm going to move on just in the interest of time, because I just wanted to go through a few case studies, if that's okay. Erin, would you so this is what we some of the questions were around the annual health check. So the responsibility of doing an annual health check lies with the GP. It's part of what we call as a quality outcome framework. So GPs are meant to provide certain service under the QUAF criteria, we call it. And one of them is a yearly health check, diabetes health check. And there are a few components of the health check. Just a quick question. Does anyone know, I've listed them on the screen there. Does anyone know why is it that we're doing these particular areas? Why are we checking for these particular things based on what Amita's just said? Any ideas on why we need to do a health check? Why do we need a diabetes annual review? Any guesses? Yeah, exactly. So actually identify complications early. So if we know that the kidneys are affected by doing a urine test, then we can put them on certain medication that will then help reverse the damage. If we know the cholesterol is high, we can put them on a cholesterol tablets. If you know there's a problem with the thyroid or the diabetes, we can optimize the management. The foot check already Amita's mentioned. Obviously, the basic bits are blood pressure, pulse, the weight, height, eye screening, smoking data, etc. The thing that is done outside of the GP practice with a referral at diagnosis is eye screening. That is done separately, and they get a call and a recall from the diabetes center in each area. And each area has a slightly different provider, but it's usually outside of the GP practice, but they share the results on an annual basis. And actually, they are pretty good. But at the practice, you're meant to bring them in, do their BMIs, blood pressure, foot check, blood test, and the urine test. And of course, if they're smokers, you discuss smoking cessation as well. I've listed the targets for those that are interested. Is the perfect level would be 48, but we need to put that level based on the patient in front of you. So if you have a really frail elderly, that 48 might become 58. So we just have to change the target based on who we have in front, and that's the role of the GP. So if some patients tell you they're above 48, don't panic as long as the GP is happy with that. I've listed the blood pressure target there as well. And anybody with a cardiovascular risk, as Amita's just explained to you, cardiovascular means heart attack, strokes, and there is a way that the GP surgeries work this out. If their risk is over 10%, they're on a statin. So not every diabetic will be on a statin. It depends on their risk, which is what you check on a yearly basis. I hope that's answered that question that was asked in terms of who needs to do the health check. Each practice works in a different way. Some have a robust call and a recall system where patients are called for the annual health checks. And it can be done by a group, a team of people, or it could be done just by the GP who sends them for blood tests, etc. So each practice will vary even within the PCN. So for the PCP workers, it'll be helpful for you to understand how the annual health checks are done in each practice. You can then signpost the patient. Some practices, to say to the patient on your birthday, just remember to book it. I didn't particularly like that way. I just send them reminders on an annual basis. So there are different ways on how people do it, but just so you remember, it's done every year. Okay, next slide, please, Erin. Okay, so this is I wanted to just put this out there for me as a GP. If I see a patient today and think actually they need a bit of diabetes help, what is it out there? And by and large, most of the support is available in all the areas. So the BMI services, if BMI is high, that means you're overweight, obese. You can refer them to exercise schemes locally. There are medications for weight loss. I've put them on, weight loss medication, Xenical. Obviously, there's smoking cessation service. Now there is a diabetes app, My Diabetes My Way, with the patients who are IT savvy and want to go on the phone. There's lots of ways they can get a lot of information and help and the targets, etc. Of course, there's structured education, but that's only at diagnoses. There isn't a top-up training on structured education, except they will have information on My Diabetes My Way app. And I will send out, and I'm really sorry I didn't provide the link to that. Most of the PCN directors should have it, but I will send the link through Erin. Obviously, the surgeries will do annual health check. Diabetes UK locally, please know your reps. They've got some excellent resources, excellent support, and they've got some champions locally as well that they can link you with. Now, this is what I wanted to just put down. By and large, a local community diabetes service or diabetes service would look like having a community diabetes team, which is where Amita sits as a diabetes nurse. That is linked with the diabetes dietitian. Separately, you will have the podiatrist sitting again outside in the community. I put CLDT team, which are probably not used well and should be. They are the learning disability team in the locality that can really help support the patients with LD and diabetes. And then, of course, you've got the IAP, which is the counseling service. And clearly from this, you can see you've got the teams there, but there isn't coordination, or as much coordination as I would like to see. So they're all still sitting separately in their little corners, accepting inter-referrals, but no coordination. And of course, there are PIP schemes, which basically are certain schemes with PCNs that are looking at pre-diabetes and how to manage them with exercise. So this is what is out there in the PCNs as it stands currently, give or take one or two areas. And you should be aware of what's happening in your local patch. Certainly in BHR, this is what is available, including the social prescribing referrals online as well. So next slide, please. So actually quite a bit. Now, I wanted to just discuss, and I am short of time, but if people want to stay for just another 5 minutes, I just wanted to go through a few case studies. And this is primarily to look at that wider social determinants. So this is a 42-year-old with LD on insulin and oral medication. He has poor control with HbA1c of 72. And remember, it's 48, the perfect level, although in his case, we might give him a slightly lenient target, but let's assume it's 48. The family, we've had a discussion with the family, looks like he's non-compliant with his medication and diet. And the family is saying, that's it, there's nothing more we can do. So any answers, or comments on how you would address this issue? Imran, any ideas how you would deal with this if you encountered this patient?
I know this sounds maybe a bit of a cop out from me, but often, if we've got a patient already on insulin who's on maximal therapy for their diabetes, we tend to refer, isn't it? We will be looking to you for support in trying to manage this patient. You can try and speak to the family, but there's one thing, Dr. Sood, I have learned today, which I did not know, and that is the CLDT team.
And exactly why I put this there.
And see how they can support. So I've actually really grateful. I've learned something.
And exactly why I put this there, because I don't think this situation can be managed just by one team. There needs to be an MDT approach to this problem. And I've got some really wonderful comments on the chat function about understanding the whys and what's, and just really understanding those wider things. So is the patient, has he got mild disability? Is he not managing it because he doesn't understand? Does he need help from that way? Do we need to get the CLDT team involved, have an MDT function to see how they can support? How do we involve the social worker? So actually this scenario throws, I don't know what's happened to the cases. Erin, I've just lost the cases. Okay, this scenario actually throws a lot of issues out there and what we can do with the PCP workers. Just the next case study. I'm not going to discuss this too much because I do want to just this one again. So this is a 72-year-old who has not attended a call and recall despite several reminders by the GP surgery. GPs rung them and said, yeah, please do attend, it's really important. And again, the same thing, the why. And in this is the patient that I know very well. She actually, all it was in her head, she didn't want to waste NHS time, didn't have the money to get to the surgery to have the checks done. But because she was old school, she just thought, it's only diabetes. I don't need one. It's fine. You can do somebody else that's more needy. And actually, it took a lot of effort or a lot of conversation from several people to get to that point. So there are other wider determinants which I think we need to be looking at. I'm going to miss the other case.
Can I just say one thing?
Yep. Imran, you're frozen. Go on.
Yeah, you know, I think I, I think that can I just very quickly tell you, a few years ago, I had a patient in their 20s who I was chasing for 2.5 years to come and see me. When I eventually got them and did the blood test, they were in end stage renal failure.
Yeah.
That's why it's important.
Absolutely, Imran, and it's important to use that wider team, isn't it? So it's really important. Those people that have to go, and
Yes.
thank you so much. But can I just ask, because we've run short of time, I've just got one more ask of you, and some of you have already put down. I hope you found the session useful, but I do want to run a series of this. I've already got an idea. Some care workers learning how to do blood sugar checks for diabetes clients and administer insulin. I'll definitely take that on board because we are planning some training locally with the care homes as well. So I'll definitely take on board that feedback. Are there any other bits of the diabetes bits that you feel that you want training on that can be done as a webinar? This is a really good practical sort of choice of training that Elizabeth has mentioned. But is there anything, please, can we put that down in the chat function or say now? And actually, Erin, we can take the slides of. There are issues, you've talked about PCN pathways, some of you, and I think each PCN will work their own pathways. They'll decide how they best manage the diabetes care, where they want the PCP roles to be involved. It's something that I think it'll be a good idea for you guys to go to your PCN CDs and get an idea of how that would look like. It may well be some of the directors aren't aware of the full capacity or the roles the PCP workers can actually play here. So really, I just want to hear from you guys. This was just a taster session, but I want to know. I've got some ideas here considering high risk. I'd like to learn more about those population considered high risk and why. Natasha, do you want to say a bit more? Natasha?
Hi, sorry.
Hi, Natasha.
I've got quite bad service, so I don't know if you can hear me. I'd be particularly interested in looking more into those who are considered higher risk, just so it's on our radar of awareness when we start speaking with patients, and we get to know a bit about their conditions, their long-term health conditions, and just looking out for the signs, I suppose.
Okay, no, that's fantastic. We can certainly develop a webinar based on that. And it's a really good point. It's all about prevention, really, isn't it? But thank you for that, Natasha.
Thank you.
Anything else, anyone else that would like to know? I hope the role of the GP, the annual health checks, the blood tests, etc., is clear to people as to why we're doing that and actually what that involves. But if there's other bits, and I was thinking things like, would you like a dietitian to go through what a good diet looks like? Would you like the exercise consultant to come through and just talk about, just some basic things you can help the client or the patient with? Is that something that people would be interested in for future webinars? Or anything else really that that would help us with the diabetes, sort of the massive challenge of diabetes, really? Okay, so diet is a good one. Yeah, exercise, you guys have said. Okay. I think there is motivational interviews for the social prescribers. There's training there already. Um, Sometimes it helps understand how the counseling services work, and just using some of those strategies, some of the CBT approaches. Obviously, you're not therapists, but just initial sort of discussions until at least they see the therapist. Anything? Weight, yeah, weight management, and there's lots out there. Okay. Cultural difference in diet, yeah, no, absolutely, and that's dietitian can cover that. So really, I've really got good ideas today, and actually some of the things that I was looking at, family and community approaches diabetes management, yeah, and that's the wider determinants, isn't it, Ninian? Yep, perfect. Okay. Right. No, so this, I'm really sorry we've run out today. I think all three of us, Amita, me and Imran, love to talk. We can talk about diabetes all day without stopping, but I do hope you've all found it useful to at least give you a taster. And primarily, really what I wanted to get across was the role and the annual health checks that are done and who to screen. But I've got some wonderful ideas on where we can develop part 2 of the program. But any feedback where you think the presentation, etc., could improve, do. Otherwise, the next presentation will bore you again with the same style.